we are back and let's keep on continue our orthopedics, shall we? This is not working. Okay, become horizontal and remove the screen saver. Okay, so we were starting the dislocation, all the injuries and stuff, but I'm going to just skip all of them right now, at least remaining topics, and then I'll come back. So we have infections of bone and joints. First we have acute osteomyelitis. It is the metaphysis of bone. So acute osteomyelitis, you have primary and you have secondary. Primary is hematogenous and secondary is following bone open fraction or a bone operation. So metaphysis of long bone is highly vascularized. The vessels from the form a loop, hairpin arrangement leading to blood stasis, bacteria settling, and osteomyelitis. So the types of metaphysis, you have extra-articular and intra-articular. Intra-articular, the thing is, infection from metaphysis can spread to the joint, resulting in a pyogenic arthritis. These are the two types of metaphysis: intra-articular, extra-articular. So because the femur is an intra-articular joint, in cases of infection of those type fever, it will spread to the arthritis also. So hairpin arrangement is there, blood stasis will occur, bacteria will settle, and osteomyelitis can occur. So etiologically it can be a staphylococcus aureus, streptococcus, or pneumococcus. So mode of infection is hematogenous. The common site is the lower femoral metaphysis, upper tibial it can be there, lower femoral metaphysis, upper tibial, upper femoral, and upper humeral metaphysis. So you can have pathogenesis, there is spread of pus along the medullary cavity. It can spread, wherein it can lead to thrombosis of venous and arterial medullary vessels. Blood supply of this segment of the bone will be cut off. Of one segment of a bone will be cut off in that case of the spread. Out of the cortex also it can spread. The pus travels along Volkmann's canal and reaches the subperiosteal region. The periosteum is lifted off the underlying bone, leading to damage to periosteal blood supply. Then segment of bone is rendered avascular, which is the sequestrum. Then you have periosteal reaction, wherein the pus under the periosteum generates subperiosteal new bone. Eventually the periosteum is perforated, letting pus out into the muscle or subcutaneous plane, leading to abscess formation, bursting out of the skin, forming a discharging sinus. Then to the joint, you can have extra-articular metaphysis. The epiphyseal plate is resistant to the spread of the pus. However, intra-articular metaphysis, the spread to the joint, hip, shoulder, etc. will occur. So you have the spread of pus from the metaphysis. First you have along the medullary cavity, then you have out of the cortex, and third you have to the joint. A, B and C. So clinical features: child is febrile and dehydrated. There is classical signs of inflammation, redness, heat, which is localized to the metaphyseal area of the bone. Abscess is there in the muscle or in subcutaneous plane, and swelling of the adjacent joint is there. So you have sympathetic effusion or concomitant arthritis. So investigations, you have to do blood investigations where you find polymorphonuclear leukocytes. Elevated ESR is there, and blood culture also you have to do. Then you have chest X-rays and periosteal newborn deposition, which is periosteal reaction at the metaphysis. Periosteal reaction strictly. What do you call this? Periosteal sequestrum formation will be there. Subperiosteal newborn also formation can occur. Periosteal reaction. Then bones can you have technetium 99, which is increasingly taken up by the bone in metaphysis, and indium 111 leveled leukocytes scan also can be done. Then it can differential diagnosis, it can be acute septic arthritis, acute rheumatic arthritis, scurvy, and acute poliomyelitis. So treatment, if admitted less than 48 hours of onset of symptoms, pus has not yet found, and inflammatory process can be halted by systemic antibiotics. If antibiotics can be provided is less than 4 years, you can give ceftriaxone and vancomycin. More than 4 years, you can give ceftriaxone and cloxacillin. Then adequate rehydration with IV fluids has to be done. Weight bearing is restricted for 6 to 8 weeks. So if admitted more than 48 hours of onset of symptoms, ultrasound examination needs to be done, and early detection of deep collection of pus needs to be done. Surgical exploration and drainage has to be done. Drill hole is made in the region of metaphysis and the pus will come out. Swab is taken for culture and sensitivity, and post-operative antibiotics and hydration has to be done. More than 48 hours. Surgical hole you have to do, swab will be taken, post-operative antibiotics and hydration has to be done. So complications, you have general complications and you have local complications. Generally you have septicemia, pyemia, and local you have chronic osteomyelitis, acute pyogenic arthritis, pathological fracture, and growth plate disturbances. Those are the local and general complications. So septicemia, pyemia, chronic osteomyelitis, acute pyogenic arthritis, pathological fracture, and growth plate disturbances. Then moving on, we have chronic osteomyelitis, which is 3 types of chronic osteomyelitis can be seen. Chronic osteomyelitis secondary to acute osteomyelitis, Gary's osteomyelitis, and Brody's osteomyelitis. So chronic osteomyelitis secondary to acute osteomyelitis, pathologically it is delayed and inadequate treatment can be the cause. Type and virulence of organism it depends, and reduced host immune resistance is noticed. Sequestrum is a piece of dead bone surrounded by infective granulation tissue. Has a smooth inner and rough outer surface because the outer surface is being constantly eroded by the granulation tissue. So different types of sequestra, you have tubular, ring, black, coralliform, coke, sandy, and feathery. Tubular is seen in pyogenic, ring is seen in external fixator. The external fixator, you can remember it as that rod itself is there, it's circle. So therefore it is ring. Then black is actinomycosis. Several places actinomycosis appears black only. Coralliform is perthes. Coke is tuberculosis. Sandy is tuberculosis. And feathery is syphilis. Syphilis, it sounds like some feather type only name. So, and coke and sandy, you can remember it as tuberculosis. Coralliform is perthes. Formation of coral-like things, perthes. Something like that you can remember. Involucrum is the dense sclerotic bone overlying a sequestrum. Holes will be present for the pus to drain out. These holes are called cloacae, and the bony cavities are lying by infected granulation tissue. So what are the presenting complaints? You have chronic discharging sinus, exclusion of small bone fragments from the sinus, fever and pain is aggravated during acute exacerbations. So investigations, you have radiological examination wherein you have thickening and irregularity of the cortices can be seen. Patchy sclerosis, bone cavity and sequestrum, involucrum and cloacae is seen. Then cyanogram, CT scan and MR and pus culture can be done. Differential diagnosis, it can be TB osteomyelitis, soft tissue infection, Ewing's sarcoma. Complications wise, you have acute exacerbation or flare up, growth abnormalities can be seen, wherein you can have shortening where the growth plate is damaged, lengthening where the vascularity of growth plate is due to nearby osteomyelitis, and deformities which appear if part of the plate is damaged and the remaining keeps growing. So you can have pathological fracture, joint stiffness will be there, sinus tract malignancies may be there, amyloidosis may be there. Pathological fracture, joint stiffness, sinus tract malignancy, amyloidosis. So going on to treatment, you can do sequestrectomy, sarcorization, curettage, excision of an infected bone en blanc, amputation you can do, continuous suction irrigation system also can be set up. Sequestrectomy, sarcorization, curettage, excision en blanc, amputation, continuous suction irrigation system. After surgery, wound is closed with the CSIS. System has an inlet tube going to the medullary cavity. Outlet tube slow section is applied. Irrigation fluid consists of suitable antibiotics and a detergent. That is continuous suction irrigation. Then you have Gary's osteomyelitis, which is a sclerosing non-separative chronic osteomyelitis. Sclerosing non-separative chronic osteomyelitis. Clinically, it can be appearing as acute local pain, pyrexia, swelling, tenderness on deep palpation. So it can also be having sarcoma and osteosarcoma. Treatment is broad spectrum antibiotics and surgical holes done in the bone to relieve the pain. Then you have Brody's abscess, which is immunity confining the infection, leads to abscess containing pus and granulation tissues surrounded by sclerosis. So clinical features you can have most common is upper end of tibia and lower end of femur, deep vein which is worse at night. Chest X-ray you'll see circular and oval lucent area surrounded by a zone of sclerosis. Treatment you can do surgical evacuation and curettage. The cavity is packed with calcareous bones. Okay, then you have Salmonella osteomyelitis which occur during convalescent phase after an attack of typhoid fever. So more commonly occurs in children with sickle cell anemia. Most common site is ulna, tibia, vertebra, and clinical features you have multiple bones will be affected. Radiological features you have diaphyseal sclerosis. Then septic arthritis is the arthritis caused by pyogenic organism. Risk factors can be poor hygiene, poor resistance, and diabetes. So causative organism can be Staphylococcus aureus, Streptococcus, Pneumococcus, and Gonococcus. Mode of infection, it can be hematogenous, secondary to nearby osteomyelitis, penetrating wound. It can also be iatrogenic, wherein the intra-articular steroid injection, femoral artery punctures for blood collection can lead to this, and umbilical cord sepsis in infant can also lead to septic arthritis. So risk factors again, poor hygiene, poor resistance, diabetes caused by the normal organisms. It can be hematogenous, secondary, penetrating wound, iatrogenic, steroid injection, umbilical cord sepsis. Okay, so presenting complaints. Complaints may be severe throbbing pain, swelling, painful limp, redness of affected joint, high grade fever, malaise, unable to use the affected limb. And you can also have child is not allowing anyone to touch the joint. That is septic arthritis. Examination, you can see high temperature and tachycardia will be there. Affected joint will be swollen and affected joint will be held in a position where the patient finds ease. Then investigations, you can do radiological investigations, ultrasound, blood and joint aspiration, culture and staining. So radiologically, there is increased joint space, increased soft tissue shadow and distended capsule due to swelling of joint. So detection ultrasound, you can see detecting collection in deep joints, hip and shoulder. Blood, you have neutrophilic leukocytosis. ESR will be markedly elevated. So differential diagnosis, it can be acute osteomyelitis, it can be acute lymphadenitis, bursitis, rheumatoid arthritis, hemophilia, tubercular arthritis. None of these are important. Don't need to remember anything. You can write on your own. Just write osteomyelitis, lymphadenitis, bursitis, etc. etc. Complications can be deformity and stiffness, pathological dislocation, and osteoarthritis. Treatment can be early stage. You have broad spectrum antibiotics, and you can do arthrotomy, which is joint opened up, washed, and closed with a suction drain. Last stage is extensive debridement of joint. Joint is immobilized in a position of optimum function and alkalosis may occur in this position. So position of ease of common joint, you can have shoulder in adduction and internal rotation, elbow in flexion and mid pronation, wrist in flexion, hip in flexion, abduction or external rotation, knee is in flexion, ankle is in plantar flexion. This is the position of ease. Then septic arthritis in infancy, which is Sahm-Smith arthritis of the hip is seen in infants, and at infancy head of femur is cartilaginous and is rapidly destroyed by the pyogenic process. So on examination, child walks with an unstable gait, affected limb is shorter and hip movements are increased in all directions. Telescope test will be positive and X-ray will show complete absence of head and neck of fever. Differentially, it could be a congenital dislocation of the head of femur, hip. Then, so you can do synovial fluid examination, viscosity, color, clarity, WBC count, PMN, leukocyte culture, mucin clot and glucose level, and crystal examination. So these are various different features are there. Volume will be more than 3.5 in almost all cases of arthritis. Viscosity will be high in non-inflammatory, inflammatory it will be low, and septic it will be variable. Color it is normal also, it will be viscosity will be very high. Color will be colorless. Generally in non-inflammatory it's yellow, here it's yellow and variable in that one. Clarity will be opaque in septic, that's the only important thing. WBC count will be usually less, but in other things it will be very much raised. PMN count will be less than 25%, but it will be slowly raising in non-inflammatory also it will be less than 25%, but in inflammatory and septic arthritis it will be more than 50%, 70%. Culture will be positive only in septic, and mucin clot will be friable in septic and in inflammatory, firm in non-inflammatory and normal. Glucose level will be equal to blood normally, and it will be increased in septic by 25%, decreased in inflammatory. And crystal examination will be positive in gout, sodium bicarbonate, positive in pseudogout, calcium phosphate, calcium phosphate. Okay. Then you have tuberculosis of bone and joint. Most commonly, it affects the dorsolateral region of the vertebrae. Vertebrae develops from scleromes which lie on either side of the notochord. Each pair develop into lower half of one vertebra, upper half of the one below it, and intervening disc. That is the scleromes. That's okay. No, I've got to do something. Give me a second. I'll come back.